I run the emergency department at Steve Biko Academic Hospital. I also have an interest in infectious diseases and outbreaks. I did a diploma in tropical medicine. And I've been following the outbreak of this disease very closely. And it's really a very interesting scenario as it develops. I want to start off by telling you a little story that happened to us at Steve Biko Academic Hospital, just to illustrate to you how these things sometimes work. We had patients coming into our emergency department, 3 patients. We didn't initially connect the dots, but we started seeing there's a connection. When we had these patients coming all from the same conference, and they all stayed in the same hotel, and they all had very, very severe pneumonias. So we started thinking, what's going on here? Why are these 3 people who are all coming from the same place, the same conference, having severe pneumonia? It can't be coincidence. And I think when I just say something now about COVID-19, it was a similar story in China. People saw people coming from a certain place having severe pneumonia, and they tried to understand what was going on there. So these 3 patients had chest x-rays, multilobar infections. We put them in our area. Often patients get stuck in our emergency department for a long time because there's such difficulty in getting critical ICU beds. And we started treating them, and then we got additional information that was quite concerning. This happened in January. There were Chinese individuals that went to the same conference. So now we had a scare. Is this maybe our outbreak of COVID-19? What turned out to transpire is, after initiating these patients on the normal critical care, initiating broad-spectrum antibiotics on these patients, ventilating these patients, getting samples, all 3 of them turned out to have the same causative organism, and that was Legionnaire's disease. It turned out not to be. Novel coronavirus. But you can see how the story is actually quite similar. So if you see something like this, if you see people coming from the same area with a severe pneumonia, you have to ask yourself epidemiological questions. What happened? Where did it come from? What organism was there? And as you know, Legionnaire's disease is a disease that often gets into the air conditioning of buildings. So I'm going to talk about the clinical management of coronavirus, and I'm really going to rely on Prof. Stolz to chip in if there's anything I say wrong. This is still new to all of us, although we are all starting to learn a lot about this disease. We are all still new at it, and I might invariably say some things that are not 100% right, and I'll rely on him to then chip in and say. So I think also I want to apologize right from the word go. I'm going to say things that was already been said to you. Don't feel bad about it. Don't be angry at me. It is just that spaced repetition is a good thing. And the more you hear things over and from different angles, from different perspectives, you understand the disease process better. So you're all here to learn about coronavirus. So I'm going to say my thing. You might have heard it before, but just bear with me. This is what we know about. This is what I know about the disease. This is my perspective. I'm working from the perspective of somebody running an emergency department, and I can have anybody walk in at any time of day or any time of night that can have anything. And I'm always looking at the NICD, and I have a session with my doctors where I scan the NICD bulletin. They've got a monthly communique. And in that communique, they tell you about the outbreaks throughout South Africa, but throughout the world as well. And I always try to update my doctors. This is what's going on out there at this point in time. And of course, all of us at this point in time is very concerned about COVID-19. And so we all know the history by now. I'm sure you've heard this a couple of times. On the last day, 31 December 2019 of last year, this thing started in China. We all know, familiar, that it started in a specific city in China, in a specific province in China. It is Wuhan city and was Hubei province. And a major component of that outbreak is located in China. This is all facts that are well known to us. We know that there's a specific virus that they identified from these patients. It is this coronavirus. And they did their tests and they identified this organism as not one of the organisms that is known. It's a new virus. We've had coronaviruses causing serious infections before. We've had MERS and we've had SARS. And in 2002, SARS was the first one, eventually located to civet cats, as these coronaviruses are all inside animals. So one of the things that are happening at the moment is we're trying to find out which animal in that open livestock market where all these cases originated from, which animal could have possibly been it. We're talking about bats, we're talking about pangolins, we're talking about a lot of things. We know bats carries millions of viruses, all sorts of viruses. Every now and then there's some major infection that jumps species into humans. And bats is often a source of it because bats have got lots of viruses on them. So for that reason, Ebola can jump into humans from bats. A lot of things. There was the Nipah virus. There's a lot of these things that happened like that. So that's why we are talking about these things. So this is the background story to this all. So the first thing that I will say is when there's an outbreak like this, there's panic. And that's why we need to stick, you've probably heard this ad nauseum by now, but we have to stick to things like the case definition. Because I have now sat on a bus next to a guy that looks like he might have been Chinese, and now I'm feeling a bit of an itchy nose, and now must I not maybe go to the hospital because maybe I'm going to die now from novel coronavirus. There's too many of these things. If you don't, we want to screen everybody and do tests on everybody, but it's not feasible because there's too much panic. Every day you switch on the television, there's stories about coronavirus. Now there's 20 more in Italy, and now South Korea is in a big panic because it's spreading too fast there. And panic. And we as health professionals must be the professionals. We must be the ones that are not panicked. We must be the ones that can tell the public, listen, you don't meet the case definition. Go home. You don't meet the case definition. So the case definition in these outbreaks is extremely important. And it is tempting to want to add things to the case definition. But if you walk past somebody that looks a bit Chinese, then it can also fit a little bit the case definition. It doesn't work like that. You have to stick to the case definition. And we have to be very strict about it. Especially if you work in an emergency department, you can't let's say you've got maybe 1 or 2 isolation rooms where you can really manage these people. You don't want to know, after a while, have to make 50 isolation rooms in your hospital because everybody is maybe having this. So you have to stick to the case definition. All right, so the coronavirus, as you've probably heard a lot about now, the reason why it's a coronavirus is it's got this sugars that is around it. And these sugars are now helping it to attach to cells. That's how viruses infect people, and that's where it comes from, corona. Corona beer, there's been a lot of jokes about corona beer, but it also has a crown, but on top. The crown on top, the nice white foam on top of it. That's why it's corona beer. But it's got nothing to do with the coronavirus. So the coronavirus we discussed, and you had a discussion about the possible animals. And like I say, there's bat soup and there's the snakes eat the bats, and it could also come from snake soup. You've had that discussion, and I think that is something that still needs to be 100% clarified. But I said already that when you have these wildlife that carries a lot of viruses and humans interact with it, there's always a possibility of something jumping species. I want to get to the actual clinical management. Let me say the first thing about the clinical management then of suspected coronavirus cases. The first thing that is going to be important, and you can hear it ad nauseum, is that personal protective equipment is extremely important. We're going to talk about it. We're going to show you how to check your N95 respirators that it doesn't leak. And we're going to talk about all the aspects, but you have to remember that personal protective equipment is the first part of the management. Now, there's some people in China, a number of doctors, and I believe some nursing staff, that has already died because they are managing patients with coronavirus. If we talk about the definition of a close contact of somebody with coronavirus, we're going to say it's, amongst other things, people who treat people with coronavirus. So it is critical that we must understand personal protective equipment is the first step in the management of coronavirus. Here we've got a disease that spreads with two mechanisms that we should be concerned about. It's not like Ebola, which is mainly droplet spread only. Ebola is just droplet. It's not airborne too. But this one, we consider it droplet and airborne, meaning we have to take droplet precautions and airborne precautions. In Ebola, it doesn't spread airborne, so you can just take droplet precautions. But in coronavirus, you have to take both precautions. That means you have to have gloves, plastic aprons, visors or goggles on your eyes. And in addition to that, you have to have a respirator that blocks out viruses, which got very filtering out all the micro things, including airborne diseases and viruses. So that's why you have to have both of those things present. Right, so before we can go any further, we have to just revisit the issue of the case definition. As I said, the case definition, your role when you're looking at the case definition and understanding the case definition is to make the case definition strict. You should not be considering all sorts of other things outside the case definition. If you are at all unsure if your patient meets the case definition, then speak to somebody. There is the NICD hotline that you can phone. There is infectious diseases specialists like Prof that you can speak to. But you should try to make your case definition strict. And the case definition consists of two components. It's got a clinical component and it's got an epidemiological component. And that's actually a very nice way to always think about these kind of diseases. I always teach my doctors also, if you think about something like rabies, think about the clinical, but also think about the epidemiological. And the same applies to coronavirus. So there is the clinical features, which include a sudden onset of cough, sore throat, and shortness of breath. And then there's the epidemiological component, where it is traveled to one of the high-risk areas, specifically China. I mean, if you think about the other areas, it's very few cases, places with populations of millions of people, and then there's like 10 cases there. What's the chances that it's like finding a needle in a haystack, that you're going to be exposed to that 10 people in Italy or so? Italy has got a few more now, but that 10 people in that or the other country. So you have to consider that epidemiological case. So the epidemiological factors then is close contact. So close contact, we must define what is a close contact. Close contact doesn't mean I'm not in close contact with the people there at the back of the hall, or even the people sitting here in front. It is face-to-face, intimate contact with somebody. Taking care of somebody inside, being in a room constantly with that person. Sitting, there's definitions for example, if you're in a plane with somebody, it's within 2 seats, or you were the cabin crew that served that person. That is what a close contact is defined. Close contact with somebody, not any person, but a person with a confirmed or probable case. All right, so that's not a lot of people that will meet that criteria. Worked or attended a healthcare facility where these people were treated. Okay, so you were in that facility or traveled to China or one of the high-risk places. Now, at the moment, as it stands, and these things are constantly changing, but that is just like a map of the world, and it shows you that China is still the place most likely. The vast majority of these cases is still in China. So a travel history to China will be an important travel history. And then if it is Southeast Asia, you will have to really speak maybe to your people at NICD to think if they actually feel those people meet the criteria to meet your case definition. So that is the second part of the clinical management. The first part is personal protective equipment. The second part is you must know the case definition well. Okay, put it up, laminate it, put it in your triage area, put it in your emergency department so that you understand it very well. Okay, so general infection control is very important. We need to look at index of suspicion. So we all here because we want to have a proper index of suspicion. Remember that you must always wear personal protective equipment. General precautions applies to all of your work. The other day I was working there in the emergency department and they were working with a patient and suddenly he became restless and he pulled out his drip and now there was blood splattering all over and later on we found out that patient had hepatitis C. So you must at all times apply universal precautions. Wear gloves, be careful how you manage things, wear a mask when you're treating people with infective conditions. Once you have now somebody that you think might meet the criteria, the case definition, you must immediately isolate that person. Isolation means you must put that person in a room alone. Okay, and it doesn't mean somebody must come and build the isolation room for you. There are many, many rooms in a hospital. You can take all the unnecessary stuff out of a room. You can leave a bed there, and then you can put a person in there, and that person will be isolated. Yes, I know Anton is going to very much dislike what I'm saying, because there are special things that you need to do to actually make such a room a better isolation room, like you must actually look at the ventilation, that you don't blow whatever that person is coughing out throughout the rest of the hospital, etc., etc. But that is the principle of isolation. Okay. And then we spoke about the droplet and the airborne precautions that you should be taking. All right. So what is wrong with this one for coronavirus? She's got goggles and she's got, but what's wrong? The mask is not right. What kind of mask is this? Surgical mask. So it needs to be N95. No, you want N95 respirator. That is what's wrong with that one. It must be there. Okay. If you do eventually get, by the way, at this point in time, I think there's one case in the whole of Africa that's been confirmed. So we're all still busy talking about a theoretical issue. There's not even a case, but we've all been screening cases. That has been, but none of the cases, I think one of them in Africa so far has been positive. But if we eventually do get some positive cases, which I really hope it's not going to happen, it's absolutely a notifiable disease. And we need to fill in the appropriate forms that you can get from the NICD website under severe respiratory conditions if you do get one of these patients. If you get a patient, isolate the patient and then don personal protective equipment and then have a conversation with somebody that can give you advice, the NICD hotline, and then we need to get the swabs that's necessary, and already you will have had discussions about how to do nasopharyngeal and oropharyngeal swabs, and then about the quality of those things. So I'm going to move on a little bit through this I'm sure you've already spoken about getting the samples and that you must get it from the nasopharynx, from the oropharynx, that you can do lower respiratory tract samples like sputums and aspirates, that under certain circumstances there are immunoglobulin tests that you can do, that you need to do basic blood work on these patients, and that you need to transport these specimens on ice and mark them appropriately to the NICD, which will be testing it. This is just a picture that you're all probably familiar with by now about the taking of the swabs and the transportation of the specimens. What I want to go on to now is, let's say we do get a patient like a patient. What are the possible levels of disease that we can have? There is mild, moderate, and severe. Okay, so mild is just and the vast majority of patients will have mild disease. We know the case fatality rate is around 2%. So meaning that most of the patients are going to be, maybe 90% of the patients are just going to have mild flu symptoms. So we don't need to panic so much about it. Then some of them will have moderate disease and some of them will have severe disease. Severe disease is a couple of things. We always think about SARS, and in the talk after lunch, I will talk about the management of the patient with severe ARDS due to COVID virus. But there's other things that can all cause severe disease as well. Do any of you have an idea what the other severe diseases caused by this virus other than SARS? You think about the respiratory component, but they can also have septic shock, right? They can also have septic shock. So let's just talk through these options a little bit. So mild disease, this will be the typical upper respiratory tract kind of symptoms that the patients will have. They will have no severe effects on their vital signs. They might have a bit of a fever. They won't have hypotension. They won't have tachypnea, tachycardia, those kind of things. And then there's moderate disease when they start having infiltrates in their lungs, but they're still coping fairly well. They need some oxygen, but there's not much more than they need, and hopefully they won't deteriorate into severe disease. Severe disease is when they actually get the multilobar pneumonia. And I'll talk a little bit about a very nice scoring system that is not our CURB 65 score for those patients. So mild cases can be discharged, right? So that is also something that we should be bearing in mind. Of course, when the patient comes in, we're going to need to take our precautions and diagnose the patient first. And for that period of time, we are going to need to take certain steps. But if the patient has got very mild disease, after we've taken our samples and everything is done, it is feasible to discharge the patient. Now, this is, of course, very important in places where there is lots and lots and lots of these patients. So if you get an outbreak where there's hundreds and hundreds of patients that are getting the disease, you can't keep everybody in the hospital. We don't have a single case yet, so we're probably going to keep these people and sit on them for a long time. But the moment the disease becomes an outbreak and you've got many, many cases, you are not going to have the resources to keep all of your mild cases in your hospital. Then you're going to start discharging these patients. And you're then going to give them very careful advice about what they should do at home. Okay, I don't know if you've discussed this already, but you will give them written instructions. And these instructions will include how they must isolate themselves at home. Obviously, if they go home, we can't send them into a place where they're now going to infect everybody else. So it needs to be a place where they can isolate themselves. Again, they need to put themselves alone in a room and not have contact with a lot of people. They need to think about how they're dealing with their coughing, how they're dealing with their hands. They need to be able to wash their hands, all those kind of things. So there's going to be careful advice that we're going to give these people if we're discharging. All right, so that is something with, that's how we're going to deal with big numbers of mild cases. We're going to give them home care guidance. We also will tell them, if they get worse, they must come back. But that is now with a big precaution. We're going to tell them that if they come back, they must phone ahead. And if anybody sends anybody or takes anybody to any place where they want them to be tested, phone ahead. Phone the emergency department ahead. Tell them, listen, I've got this person. I think he meets the case definition. He's traveled to China. Now he's got a very sore throat and a temperature of 38 degrees Celsius. I want to bring him to your emergency department in about an hour's time. Can you please get ready? That's so helpful because now everybody there at the emergency department can start getting their N95 respirators. They can get an isolation place where they can evaluate this person. And the same will apply if we're going to come to the point ever where we're going to discharge mild cases. We'll tell them if you come back, phone ahead so that we can prepare for you. And we'll, of course, educate them about how the disease can progressively get worse. And we know that one of the common ways that this disease gets worse is becomes a very severe pneumonia. And that's what kills people, especially old people, right? And sometimes pregnant patients, patients with immune compromise, they're the ones that are at risk of dying. Severe cases, like patients with severe pneumonia, ARDS, sepsis, and septic shock. These are the definitions of the more severe cases. Now, I'm not going to actually talk now about the severe pneumonia and the ARDS because that's actually the next talk, where I'm going to just talk a little bit about how to manage these patients. And it's mainly going to be to do with ventilation of these patients. Obviously, if the person has got a severe pneumonia or ARDS, they must be managed in a ICU setting. There's no antibiotic at this point in time that is very effective in treating coronavirus. So how we get people through it is we allow the body to heal by itself over time. And the body can eventually defeat the viral disease, but you must prevent it from dying while it's trying to heal it by itself. And we do that by special techniques of ventilating the person and so on. But that's what we're going to talk about in the next talk. Now, I just want to go back, and I don't know if I've mentioned it here. The more moderate cases, like let's say the milder pneumonias, here we're going to specifically treat those patients. We're going to admit them in an isolation area, and we're going to just give them standard oxygen therapy. Okay. So standard oxygen therapy means we are going to treat them with oxygen masks, and we're going to give them additional oxygen, and we're going to be aiming for them to have saturation at least above 90%, and specifically pregnant patients, we want them to have a saturation of more than 94%. So these people will be admitted, they will be treated. I'm probably going to mention it later again, but they found that coronavirus is associated with a particularly high percentage of secondary bacterial infections. So where, let's say influenza, which is a common respiratory virus that we deal with, they can do all the things that corona does, can also cause severe pneumonia, but not as often. The number of patients with a secondary bacterial infection is not that high. But coronavirus has got particularly high percentage that's got secondary bacterial infection. So what you're probably going to do if you're milder pneumonias is you're going to start a broad spectrum antibiotic. But you'll be doing this will be something in consultation with an infectious diseases specialist, all right? This is a very useful scoring system. Okay, now this, we all know the CURB-65 score, which we normally use to determine the person have got 2 or more CURB-65 criteria, then we admit them to hospital, but that applies to bacterial pneumonia. You can use CURB-65, but this scoring system is considered a better scoring system for viral pneumonia. So if you want to determine how sick my patient is, and I just want to bring you guys back and just orientate yourself about what we're talking about now. At the moment, we're talking about treating somebody with a severe coronavirus pneumonia. We haven't had a coronavirus yet positively identified. So this is where we're jumping the gun now. We're far ahead of ourselves. In case we get somebody and that person turn out to be very sick, then we're going to consider this scoring system. Okay, so that's where we are. This scoring system tells us a little bit about coronavirus because it tells us a little bit about the aspects. And it's nice because it starts, the things on top are the most closely associated with poor prognosis, or it's got the highest odds ratio for the patient requiring intubation and ventilation and admission. Okay. So, and then as it goes down, it is less and less and less. So the thing that is the most predictive in a patient with a coronavirus pneumonia is it affecting multiple lobes, right? So it tells you that these viral pneumonias, if they get really bad, they almost become like an ARDS. They get a multilobar infection. You can picture a patient like this lying in front of you. How will that patient look if he's got a multilobar pneumonia? He's going to look sick. He's going to look tachypneic. He's going to breathe fast. And I just want to emphasize again, after putting on all your personal protective equipment, if you examine this patient, you're going to hear crackles all over the chest of this patient. It's going to look like he's getting tired if he can't cope, you see. And so if it's multilobar, you do a chest x-ray on this patient. Chest x-ray, by the way, do portable. Okay, don't let this person now go there, cough there between all the other ones lying there for their fractures and so on. Bring the portable chest x-ray in, do the chest x-ray there in isolation for the patient. Okay. You see multilobar, it is serious business. Okay. Then the second one is going to be lymphocytopenia. the patient has got lymphocytopenia. That is a typical feature of bacterial pneumonia, right? So normally, viral pneumonia. Bacterial pneumonia causes neutrophils to go up, and this one causes this picture. Right, then bacterial co-infection is another prognosticating factor. And like I said, coronavirus has got a higher incidence of bacterial co-infection compared to other viruses. So it's almost always necessary to give a broad-spectrum antibiotic. Then the next one is this person a smoker? That is obvious. It gives, all the effects of smoking affects the prognosis of the patient. The cilia are all affected when a person smokes. And so they can't clear these things as effectively, so the pneumonia gets worse. Hypertension, which is just one of those things that you just sometimes find, like hypertensive patients are also part of this, and then age above 60. So this is your scoring system with which you will be scoring your patients with pneumonia. Here is a picture. If you do that mobile chest X-ray and it looks like this, you know your patient has got severe acute respiratory syndrome, SARS. If this patient meets your case definition criteria, this patient has got SARS, and the patients generally who die from coronavirus, they are the ones that get this. Okay, and this is not the only way to treat this is to put the person in isolation in ICU. So it's an ICU isolated patient. And then you're going to do supportive management, and we're going to talk in the next talk about how to ventilate these patients. And you're going to do the fluid management, and you're going to give the broad spectrum antibiotic for those secondary bacterial infections. And then the person is going to go a little road over a couple of days where the person will either gradually get better, or in some sad cases, they're just going to not get better and they're going to die. And that is the way it happens. Okay, so I'm getting back to that moderate disease now, and I just want to point out moderate disease, one of the first steps. Here's the steps that we're going to take for moderate disease. That's not the ones that you can't discharge, but they're also not the ones that necessarily have to go to ICU, so you're just going to put them in a normal isolation ward bed. And you're going to apply oxygen to them so that their sats is at least above 90%. And more than 94% in pregnant patients. Remember, in pregnant patients, we're treating the baby as well. And pregnant patients in these viral infections, they're always a high-risk subgroup, just like aged patients. Aged patients are a high-risk subgroup. So you cannot treat a moderately sick coronavirus patient if you can't administer oxygen and if you can't monitor oxygen. So at least you must have oxygen points, and at least you must have SATS monitors in that place where you're treating these patients. Use conservative fluid management. We don't want to now, because somebody is giving so much fluid to these patients, push them into that ARDS picture with fluid. All right, if the virus can't do it, then we push them there with fluid. So we use a conservative fluid management approach. We give empiric antibiotics. Don't give steroids. I know many people are just always giving steroids for everything. This is not one where you must give steroids. The research on steroids indicate that coronavirus patients, SARS patients, they've done this on the previous outbreaks, the SARS and the MERS. They found that it is not it doesn't improve the outcome, it worsens the outcomes. It takes longer for the virus to clear out of the lungs. It suppresses the immunity a little bit, so don't give steroids. Then these patients we're going to be watching closely. We want to see, are they going to get better? Or are they going to gradually get worse, so that we need to intubate them and put them in ICU? All right. So we need to monitor them. We need to assess their vital signs. We need to be looking at their SATs. Are they starting to breathe faster and faster? Are they slowly, is their chest X-ray getting worse? So we're going to be monitoring them all the time they are being admitted in an isolation facility. We must also prognosticate and communicate to the families. This is basic stuff that you should always be aware of. If we see that this patient is maybe 80 years old and the patient is getting worse, we must prepare the family that this situation is not going in the right direction. Okay, so I know prognostication is always a very dangerous business. in medicine, but we need to at least give the family some sort of indication of what the direction is that the patient is taking. Now, the next I'm going to talk about two severe diseases, and it's not going to be the respiratory one because that comes in the next talk. ARDS I'll discuss in the next one, but the management of septic shock. So these patients can also become severe from septic shock. That's not something that we always mention. When we talk about severe cases, we always think about the patients who develop the severe multilobar pneumonias, but they can also develop septic shock. So there is a definition of septic shock that you should all be aware of. Okay, so the definition of septic shock is if you have a patient who has got a confirmed infection, and that patient is hypotensive in spite of fluid administration and needs an inotrope to maintain the mean arterial pressure above 65. That is the definition of septic shock. All right. And those patients, these coronavirus patients can meet those criteria. Then we have to manage them in a very specific way. Also, the lactate must be more than 2. That's the definition of septic shock. The steps that we can just share with you is that we must avoid fluid overload in this patient. Again, we don't want to push those lungs into an ARDS picture with giving fluid. At the same time, we have to manage septic shock by administering adequate fluid. So you see here the regimen that they actually recommend is for an adult 30 mils per kilogram over the first 3 hours. So normally we just give a bolus of 20 to 20 mils per kilogram. So it's slightly more reserved fluid management. And in children we give quite a lot of fluids too. We avoid any of the hypertonic fluids and starches. And then we're going to put these people on inotropes. And then we are going to aim for some perfusion targets. So we're aiming for these people in septic shock that their blood pressure, the MAP, mean arterial pressure, must be above 65. We're aiming for them to be at least have enough perfusion that they are awake. We're aiming for the mottling of the skin to improve. We're aiming for the capillary refill to improve. And that is how we're going to manage them. So this is stuff like, this is going to happen in ICU, and it's more for your information unless you're an intensivist, that's actually going to now be the one that's going to have to manage that one and only coronavirus case that we're going to get. But this is the principles of what we are going to be doing. And then further goals of treatment is going to be really the standard things that gets done in ICU. So we want to reduce the day on the ventilator. We're going to try to reduce VAPs. We're going to give Texane to prevent DVT in these patients. We're going to try to be sterile when we put up central lines for them. We're going to remove the central lines early. We're going to turn them every 2 hours. We're going to do prevention of peptic ulcer disease by giving them early enteral nutrition, PPIs. And then we're also going to reduce muscle weakness by mobilizing these patients. We'll talk a little bit about sedating these patients in ICU during the next talk. Pregnant patients. You have to have awareness of if your suspected case is pregnant. All right. So in that scoring system of ours, we had age as the last one. So age is always an issue with coronavirus. And if you look at the deaths so far, most of them have been elderly patients. We know that elderly patients sometimes struggle to deal with pneumonias compared to younger patients. Now, pregnant patients are also important. So if your patient meets the case definition and she is female, you must become early aware, is she pregnant, yes or no. If she is pregnant, she is at higher risk. And we need to take some additional steps to treat her, and we need to be even more vigilant. We're going to essentially use the same supportive treatments, but we need to just be aware of the physiological changes of pregnancy. Pregnant people, especially in the later part of pregnancy, they have got changes to their lungs. Unfortunately, the lungs are the place where this virus can attack. And if you now have a big gravid uterus, it can make situation worse for you, because now you've got reduced functional residual capacity, got increased risk of aspiration, and that can all make your lungs potentially worse. So we have to think about that. We have to think now a little bit about making choices here. Let's say this person is extremely sick. We need to think about getting this, delivering the baby before that she actually goes into arrest. So we need to consult with obstetric specialists. So we need to consider delivery and termination decisions is basically individualized per patient. You have to consider the gestational age of the baby. You have to consider the maternal condition. So those are things that we're going to take into consideration. And then the fetal stability will all play into that decision making about pregnant patients. The last slide that I'm going to talk about is just for you to give you some information about, again, should we get one of these patients? What are some of the treatment options that are on the table? Okay, so there are now in China busy giving some antivirals to these patients, and some of these antivirals have been proven to be promising. So I would say, again, we're getting very far ahead of ourselves. This is some decisions we're going to make once we actually have patients with coronavirus. But you should be aware of the fact that antivirals and vaccines have got a role to play in the management of these patients. And it's something that you, at some point in time, if you're actually managing a patient with coronavirus infection, either with moderate disease or with severe disease, you're going to say, are we going to give an antiviral to this patient and treat the patient? So, yeah, I would strongly recommend that if you don't just randomly start pulling out your own ideas about someone starting to give antiretrovirals and things, I think this is something that should be done in consultation with an expert in infective diseases and pharmacology. So there's a number of antiretroviral drugs that are now moving to the forefront. So in China, they've got favilavir that has been approved for treatment of patients, and some patients have had an improved outcome. And as far as I know, this drug is not available in South Africa yet. It might be. Then there was an Ebola drug that they are currently at stage 4 clinical trials. And then you can also consider HIV drugs. This is not something you can just generally consider. It's something you can consider in consultation with an infective diseases specialist. So we know that the coronavirus is a RNA virus, just like the HIV viruses are RNA viruses. But now the HIV viruses, they are retroviruses. So part of our ARVs is reverse transcriptase inhibitors. That's obviously not going to work for just a normal RNA virus because it doesn't have reverse transcriptase. But the protease inhibitors, they can potentially work. And in the SARS and the MERS, they have put some patients on these drugs, and they found that it does have some potential benefit. So that is something that might have a role to play. Anton, yeah, I'm relying on you to say something if you've got any specific opinions, but that is where we stand at the moment. That's something that we're going to consider to start administering to patients. We're quite used to giving Calitra, which is the protease inhibitors. So that is something, if we have a serious case, we're going to consider that. It's going to be on the table, all right? So don't be surprised, what's going on here. Why are they giving these antiretrovirals now to these coronavirus patients? It is also an RNA virus and it's got potential benefit. The Chinese and various pharmaceutical companies are working very hard on trying to find a vaccine. And there's now predictions out there saying that China might have a vaccine by April. I think it might be very optimistic, but the big pharmaceutical companies obviously is working on developing a vaccine. People, that has been my attempt to give you an idea of the clinical management. If we are going to get some of these cases, we're going to decide mild, moderate, severe, the mild ones. In the beginning, I know there's going to be so much hysteria around it that we're just going to keep those patients till kingdom come. But if it ever happens that we're going to have a lot, we're going to start discharging them with advice. The moderate ones, we're going to admit in isolation rooms. I'm going to work with them and monitor them that they don't get worse. The severe ones, we're going to manage in isolation in ICU. And we're going to have a specific strategy about how we're going to manage them. And then we are also going to have the possibility of using some antiviral medications on these patients. But that's more or less the picture as it stands. If you have questions, I try to answer them, but I'll also rely heavily on the panel to assist me with answering any of those questions.
Thank you very much. With the presentation of extremes, i.e. your asymptomatic and your severe, what is dictating it? Would it be the state, i.e. of the immune system, i.e. those who are not severely infected, are not having pro-inflammatory process, the other side is, and also does the worsening and the cause of death really kind of explain whether your complement system is really overrun, the liver is not able to sustain, and when the virus comes in, there is just basically no backup for it. And then your immunoglobulins are also shut at being so way down that to actually build up some kind of novel immune system, taking into consideration also your complement system. Is that the reason why we're having these drastic pictures? Because on the whole, it's the same virus in both individuals.
Correct.
But different presentations. What's your view on that?
Right, so I think you're raising a very good question. So the first thing is that, as I think you said yourself, that the immune system plays a crucial role in viral disease. Antivirals is actually not, they can make a bit of a difference, but they don't play a crucial role. It's mainly the immune system itself that has to defeat the disease. Now, that means that, firstly, individuals who have got, for some other reason, a depressed immune system are at higher risk. And, for example, we're all well aware of the age-related issues with the respiratory system. That's why elderly patients often have disease, have more severe disease because, it's also has got to do with comorbid disease. So if I say, for example, a patient who has got congestive cardiac failure, or a patient who has got underlying chronic obstructive pulmonary disease, that patient already has got limited reserves in those organ systems. So the chances that they will get more severe disease is much higher. Okay, the pregnant patients, I already alluded to the physiological changes in pregnancy that is associated with it. Now, the technicalities about which part of the immune system actually combats viral disease, whether it is the cellular, the humoral immunity, the complement system, there I am actually not 100% sure what the best answer would be to give you to that one. But I know that there's those components of the immune system are going to play an important role in combating the disease. And whether it's complement or complement itself, I actually can't give you an accurate answer on that one. I don't know, Anton, if you want to elaborate on that a little bit.
All I can add perhaps is that if you look at viral infections, the pro-inflammatory and the anti-inflammatory, that must happen because what is important about infection is the pro-inflammatory. If your body do not check what will happen, the secretion of cytokines that pushes you, like interleukin 1, 12, interferon gamma, those things send you into a state of pro-inflammatory areas, and that can actually kill you by itself. So the pro-inflammatory cytokines that is secreted must be checked by the anti-inflammatory, the interleukin 10s and things like this. So otherwise, you're going to be in problem. And it is now very difficult to decide because we don't even know where it attacks, what it does. So at this stage, I can't say what it is, but this is usually in viral infections where you get this pro and anti-inflammatory play between the things.
From my understanding in reading, it seems that your NK cells, your natural killer cells, within the innate system would form the basis of regulating and controlling viral infections, because your antibody acquired immune system would occur 3-4 weeks later, if at all. So I think the failure of the innate system is the crux of the matter. Now, in individuals who have, I'm looking at it, where we have patients, HIV, PCP, and others, what are our chances in terms of survival in those kind of patients? Thank you.
I think the one thing that I also just want to point out is that you can have perfectly young, healthy patients also die from this disease. So it's not exclusively an issue of immune suppression, but immune suppression and age, immune suppression, comorbid disease, pregnancy, all those things are known risk factors to produce more severe disease. Okay. You know, I come from it from a clinical approach. So to me, the nitty-gritty of the immune system is something that we still need to clarify. I think we need to, at this point in time, in terms of how we view this and how we prognosticate about it, we should take into consideration the known clinical and factors that we've learned from the previous two SARS diseases, the MERS and the SARS, and we should use that as clinical guidelines. I think the immunologists and the virologists will still clarify for us the nitty-gritty of the actual immune system, but the immune system essentially must play its role to combat the virus, because ultimately it's the body that must be supported clinically to fight the infection until it clears itself. The body has got ability through natural killer cells and through the immune system to defeat viral diseases. But sometimes when that system is either over-regulated, in other words, causing more severe inflammation than it should, well, then it can become a problem in itself, and then you just need to basically manage the patient and support the patient through that phase.
Thank you for the presentation, Professor. So how does this management of COVID-19 severe cases differ from your management of the other severe flus? And why now this sudden panic or increased intensity with which we are approaching COVID-19 if the world has basically gone through very bad flus before?
So firstly, there is an element of, there is an element of hysteria. I don't think we must deny it. The world and it's a given fact that there are respiratory infective viruses, coronaviruses, influenza viruses, etc. And to answer your first question, there's not really a big difference in the way we manage one viral severe pneumonia from another viral severe pneumonia. The way you manage a severe viral pneumonia is pretty much the same. It's generally supportive management because antivirals are not that effective. So there might be that there's slight differences in which antiviral you use. You know, for example, for influenza viruses, you're going to use different antiviral treatments compared to coronaviruses. But we're probably going to use the lessons we learned from SARS and from MERS to treat these coronaviruses in terms of antivirals. And of course, the vaccination is going to differ. But I think one of the reasons why there's quite a lot of concern about this specific outbreak is the rapidity with which it has spread in China. Even if you assume that only a small percentage of all the people that are going to get a coronavirus infection will get SARS, if that coronavirus spread very rapidly, you're still talking about huge numbers of people that are going to flood the health system with very severe pneumonia. So if you can contain it, then I think it is a great benefit. Because if you just let it spread freely, so it's just like flu. Let's just let it spread. And let's just let nature take its course. Then you're going to really have a situation where you're going to have too many people coming in with severe pneumonias to the health system, and the health system won't be able to cope, so you're going to let people die on the streets. So now what we say is let's just rather contain it and try to not let it spread so far so that we don't overwhelm our health systems with too many patients who've got severe pneumonia. But in a sense, you're right. There is a bit of a hysterical element to it because, we are going to have respiratory viruses causing pneumonias unless they come up with some magic bullet or something to stop it. But it's nothing different from the other ones. But they did cause a lot of problems, those MERS and SARS, because they, other than influenza, where influenza, there's just a few people that get a severe pneumonia. It's quite a rare complication from influenza to cause a severe respiratory pneumonia, multilobar pneumonia. These coronaviruses, they cause it quite often. So that's why it's a bit of a problem, yeah. Okay, yeah.
Just add something.
Yeah.
I think to answer your question also is that it's the amount of unknowns that is making us frightened. Okay, so until we understand it, I think we will be frightened. As soon as we start to understand it and see that we can treat it, then that fright will go away. So I think that is the main thing of unknown, what is going to happen. I think that's the main thing at the moment.